lutetium PSMA-617 showed clear survival benefit in the VISION trial, which is post-androgen receptor pathway inhibitor, post-docetaxel. It is now FDA approved. We had some supply chain issues, but it's now largely resolved and available for patients to get access to, certainly in the United States and in certain other countries as well. PSMAfore was in the docetaxel naive population for metastatic castration-resistant prostate cancer, and it is a big population. It's the population that basically gets an androgen receptor pathway inhibitor and the PSA starts to rise. And the good news is that that's a large heterogeneous population, because you can get the androgen pathway inhibitor for metastatic castration-resistant prostate cancer, for M0 castration-resistant prostate cancer, and even for M1 or metastatic castration-sensitive prostate cancer, coming from abiraterone, coming from enzalutamide, apalutamide, darolutamide, a whole host of all these different agents. So I think that the data from PSMAfore was very impressive. If you look at the radiographic progression-free survival benefit, it essentially doubled as well, from around little less than 6 months from the control, which was androgen receptor pathway inhibitor switch. So if you had abiraterone, you get enzalutamide, enzalutamide would get abiraterone, that sort of switch, versus lutetium PSMA-617. I think that sort of radiographic progression-free survival benefit is very, very impressive. The one issue is, will it translate to overall survival benefit? Well, they had 84% crossover, meaning the study allowed you, if you were randomized to the AR pathway inhibitor, upon progression, you could cross over and receive lutetium PSMA-617. With that high level of crossover, could it eradicate the overall survival benefit? Maybe. We have to wait and see. However, rPFS probably will be enough in this situation. And why? Because rPFS has been validated as a decent marker for approval in prostate cancer. I'm going to add a caveat. And that caveat is that the one drug that got approval for rPFS was abiraterone. The old Cougar 302 study, they got approval because they already had survival benefit from Cougar 301 with abiraterone in the post-docetaxel setting. This is analogous. Lutetium PSMA-617 already has overall survival benefit in the post-docetaxel setting with VISION. So even if they don't hit overall survival benefit, rPFS is probably enough. The conversation changes if, let's say, you took a novel agent that has never shown overall survival benefit. Will rPFS be enough? Question mark. That's a question mark for the regulators to decide. But I think there's a precedence for this with abiraterone. I think that it should pass the muster with rPFS, and we'll keep our eyes closely on what happens with OS.